All right, good evening, everyone, and welcome to The Last Word. You're right on time for the most impactful, most consequential show on this part of the world. Well, we're used to this question, medics being on strike, nurses, doctors, and it's been the time for clinical officers. Would you believe it's been 35 days since the clinical officers have been on strike? And so that makes us ask the question, what has been the impact of clinical officers being on strike in the last 35 days? Have you felt it? How has it affected you? But most importantly, we want to ask this urgent question. Should the government accede to the clinical officers' demands, which will tell you, among other things, like many other strikes, is the question of collective bargaining agreement. Agreeing to pay or not agreeing to pay. What we've seen in the last 30 or so days has been sort of unwillingness by state or government to accede to these demands. My name is James Smart. As always, I do have the usual culprits on the program, Zaha Indimuli and Eric Latif. Gent, lady, good evening.
Good evening.
Evening, Smart. It's a big conversation, this one, to have. Every time we see medics going on strike, we always ought to remember that these are people who should be taking care of people who are vulnerable at a point. You don't go to hospital mostly when you're not well, unless when you're just going for, regular checkups. But majority of the people will go to a health facility seeking care. Yeah. And if you land there and you find the person who ought to be giving you care is not in, then just tells you that you've been left to your own devices. Now, clinical officers, how many clinical officers do we have in the country, and where do they serve?
Right.
Many people in the country just know ukienda hospitali, the person wearing a lab coat, huyo ni daktari, right? Ni muuguzi. But many of them are clinical officers, and then now you'll have the doctors. Clinical officers, if you go to a level 2, level 3, level 4, level 5, and some level 6s, you'll find clinical officers in level 6s as well. But a majority of them will be, if you go to a level 2, highest chances are the person that you find there is a clinical officer. Level 3, level 4 as well. So if they're not at work,
what's happening in those places?
What's happening in those
Exactly.
Because I think the thing that we've normalized, I think, as a country, is this idea that strikes, and especially biomedics, as Latif says, is a thing that we have come to normalize. And the impact of that gets somewhat minimized. Every so often you'd see a case or two of a family or a patient that has gone to this facility and didn't find the medics, or for some reason, unfortunately there's, a death has occurred. And those few incidences then make it to the news. However, the complete impact of what happens when medics are not at the station of work is not a thing that I think as a republic, as a country, we've been able to internalize and say, why has this been a thing that we've normalized? Why is it possible that in a year, doctors can go on strike maybe twice, nurses 2-3 times, clinical officers, whatever it is? Zaha.
I think it's so interesting because at the brink of a nation's sovereignty is the existence of a healthcare system that supports both the patients and the people who are accommodating the care. So I'm very interested to also learn what is the healthcare system accountability and who exactly bears the front of making sure that the people giving out the care are well taken care of to give primarily good healthcare services to Kenyans. And what is the worker dignity in these spaces? Are our clinical officers and our nurses and doctors well seen and well appropriated to do their work? And what is public access to care during these strikes as well? Because at the same time, where do we draw the margin of ensuring we respond to public officers and health workers as well as looking at victims who come to these hospitals and then they don't see this facilitation? So who exactly bears the brunt, and where does the government sit in looking at the most critical system in our country fall apart when we can have strikes going on for a whole year, back to back, from our doctors to our nurses, now to clinical officers? 35 days is a very long time. And I know between the work of being a clinical officer, you understand the dignity of the patient and you know exactly what's happening. But who takes care of you? Who ensures that the things you require are very much mandated for? What is happening to the CBAs? Who's doing the negotiations? Why do we keep having a repetitive sort of a system in Kenya where public officers and especially healthcare workers have to go on the streets to be heard? I think those are the things I want to understand today.
Absolutely. I have to say that speaking of government, we did invite Dr. Omologo's PS Medical Services. Up to the time of coming to this program, he had confirmed his participation. So far, he's not here. We're still expecting him, and we'll keep asking questions as if he's in the building. However, in the building though, we do have Peterson Wachira, who's the national chair, Kenya Union of Clinical Officers, and a room full of clinical officers. Ladies and gents, karibuni sana to the program. We really want to know, Kenyans, once we put out this thing, asking like, who are clinical officers? What in the world do they even do?
Yeah.
So this is your chance tonight to educate us as we discuss the biggest issues that we have to discuss, which is the question of, does the government really care about healthcare in general as they deal with this question of clinical officers and how they get back to work, or they even get back to work? Let's start from there.
Indeed.
Right.
Or maybe just from that point, like you said, Smart, it's important just to know who's a clinical officer.
Yes.
Right? I mean, so I said, people wearing white coats in a hospital, what in madaktari? So these guys, if they wear white coats in a facility, who are they?
Yes.
Maybe we start with the national chairperson of the union, Peterson. Who's a clinical officer?
And why not in a white
lab coat?
Why didn't you get
Because he's on
with your
strike.
live brush coats? Or you're in strike. You're like, you've downed your tools.
Thank you. Thank you, and thanks a lot, especially for this program. And I must say that you are doing a really good job. This is one of the panels where we listen to and we learn a lot, and you're doing a lot of civic education. And I think we must give you your flowers.
Thank you.
So on to the question that you have asked, who is a clinical officer? A clinical officer is a clinician who has been trained in clinical medicine to offer mostly primary health care in this country. So we go through the college or university. You either do a basic in diploma for 4 years, including 1 year internship, or you do a degree for 5 years, 4 years in school and 1 year internship. We also have specialists, and we have 2 levels. We have at the diploma level, we call it higher national diploma, where you specialize, like most of the anesthetists that you know, they have done that. And we also have a master's level, where after you do your 5 years, you work for another 2 years, you're allowed to go back and do your master's. And currently, now we can go up to the PhD level. What do we do? If you have been to any public facility in this country, I can assure you, you have an 89% chance that the clinician who treated you is a clinical officer, because mostly you find the general practitioners in the outpatient. And if you check our records, about 89% of Kenyans will come to the hospital, will be seen in the outpatient, and they'll go back home. They are seen by clinical officers. Only about 11%, of course we see the 100%, but 11% of those we are going to admit into the wards for follow-up. And that is where now you meet a medical officer. That is where you interact with them. And so basically across the country, at any level that you go, the highest chance is that the clinician who saw you is a clinical officer, and if you are admitted, the one who saw you first. If you went to theater, you have a 97% chance that the anesthetist who attended to you is a clinical officer. If you had an eye problem, if you had a cataract surgery, then you have a 99%, because the number of cataract surgeons in this country, the doctors only account to 1%. The others are actually clinical officers. And I can go on and on, because we have around 21 specialties where we specialize in, and we have been providing that service for this country for the past, that is from 1928. In 2028, we'll actually be 100 years old in this country. If you go to some of level 6, like MTRH, we have about 250 clinic officers, both in the outpatient and in the inpatient. And for those who have been there, they can attest that MTRH, Moi Teaching and Referral Hospital, is one of the best level 6 that we have in this country. So we are at all levels. We are either general or specialized, and we are the primary clinicians who actually have been carrying the health burden in this country.
I have to complete your statistics that everyone who'd pick a microphone, you have 100% chance that will be a clinician that will be speaking tonight, just to finish with the statistics. But thank you very much for these records, because then we start from a very knowledgeable place that shows the public where they meet clinicians, the services that clinicians offer, and the centrality of clinicians in our healthcare system.
I have one more question on that, and that is, so you're trained differently from a medical officer, and therefore you're also licensed differently from the medical officers, the doctors, right? So who licenses you? Who regulates your practice? And who employs you?
Yes, so as a matter of training, there is a difference between the training in clinical medicine and the MBCHB. So doctors go through a program called MBCHB. We go through a program in clinical medicine. And the main difference is usually in the surgical part. They're able to go a bit further than we do in surgery. They can do more invasive than we do. And that is why they serve as secondary clinicians. Where a clinic officer reaches, then they can take up from there. So we are registered by the Clinic Officers Council, pursuant to the Clinic Officers Act number 20 of 2017. And the doctors on the other side, they are registered by the KMPDC, Kenya Medical Practitioners and Dentists Council. Yes.
Who employs you?
So we are employed basically across the private sector, the public sector. We have so many in the NGOs. We have those who decide to go back to teaching. We are teaching in KMTC, in universities. And we also allowed by law that after I have 3 years of experience, I can actually open my own facility and employ myself.
All right.
And we also have so many clinic officers in research, actually.
So can you open up to a few more people? Just as, you know, a question that the public has asked us. Do professionals in this room, clinical officers, do you feel your role is either appreciated or underappreciated by the public? And I would add, why would we think so? Either way. All right? Let's just open up and just get the feel in the room. Let me start with you, Mike, because you have your microphone. Please introduce yourself, what you do, and take us up from there.
Okay, thank you very much, James, and your colleagues. My name is George Gibora. I'm the General Secretary, Kenya Union of Clinical Officers. And I must appreciate for giving us this opportunity just to highlight our issues and our predicament. And I think that goes in line with the question you're asking, whether we are appreciated or not. And I think the level of appreciation can be seen in terms of our absence in those facilities. Today, facilities are grounded. Hospitals are not working. And those we believe that then the Kenyan appreciate the kind of work we do. I think the question will be whether the employer, especially the government in this question, appreciate the work that we do. Even if there is an appreciation, I think I can just say they appreciate when you are doing the work, but not by reward. When you are at work, they want you to do the dank work, but do not really acknowledge and give you that full appreciation in terms of what we are now crying for. We have been crying for the CBA for more than 8 years. If you believe then that we have a functional system, there will be a question whether really we are appreciated. If we are pushing for people who are under punitive terms like the UHC staff for more than 6 years, that they can be converted to PNP, and that be still an issue, you have the legitimate question whether the employer appreciates us. And also, looking at one of the point where we have the former Global Fund staff working for more than 20 months without pay. The employer wants you to work, they don't want to pay you. They put you on a dut rota without paying, It indeed clearly expressly shows that the employer does not appreciate what we do, but they want us to continue working. And it brings us to the point of priority in terms of the employer, whether then you want service to be offered, but the people you want to offer, that they can offer services, you are not supporting them. And it points out to a fragmented system, which is not about clinical officer, but all the healthcare workers, because you started by mentioning that there have been strikes, not just by clinical officers, but all the other healthcare workers. So there is a question of priority in terms of implementing our constitutional Article 47 and what it dictates what the state ought to be doing in terms of offering services. Thank you.
I have a question, sir. Then what would you want the public, as patients, for example, and just the general public to understand about why you've reached to this point and how supporting clinicians ultimately protects patients' lives? What has pushed clinical officers to this point currently? Because of course, we know how this government works and how it has been all over time, but why exactly did it front to a strike?
As I mentioned, I'll still repeat it, that we have issues that I can clearly say they are historical in nature, historical injustices. I mentioned about the CBA. A life cycle of any CBA is just 4 years. Then it beats any logic that you negotiate for the same with CBA for 8 good years. That you have been patiently waiting and looking for the same, that it can come to better the terms of the employees, but the employer is resistant and not willing to do it. And even to some extent, we have agreement in terms of how it ought to be done. They do not act on their part. They do not implement the part of the agreement. In case point is where in 2024, if you remember, we had a long strike, close to around 7 months. We had an agreement that the CBA was to be concluded within 3 months. We gave them a latitude of 1 good year. The whole of last year, they never concluded it. They never wanted to come on the table. So when it came to December, we felt like we are not willing to continue waiting. We wanted to push the employer, taking the advantage of what the Constitution gives to us under Article 37, so that they can come on the table and finalize on this CBA. We issued a 21 strike notice. 21 strike notice, when you issue a notice of 21, meaning we are expressing our goodwill, that if then the employer was willing and prioritizing our issues, it will have been addressed then, calling us on the table and actually addressing all these issues. Because we believe that we had already done the greater part in terms of negotiating the CBA, and then any opportunity within a table for more than less than an hour, we'll have concluded the CBA and avoided this industrial action that has now is now actually affecting very many people, and they are not able to access services. But more so, I must say that Kenyans must support the clinical officers and other healthcare workers, because if we are not supported at the end of the day, this is what pushes the healthcare workers to mental anguish. And if then you are at that state as a healthcare worker and you are the one to take care of those patients, you are putting the patient in danger. That you have nothing to appreciate the work you do, that you cannot be able even to afford the services you offer to patients. That put us in a very precarious situation. And that is why we want Kenya. And when we are out, we are pushing that the government must give us a medical cover that really can be able to suffice, or rather give us medical services when we need it. We are pushing that we must be able to be remunerated in a manner that we can be able to take care of our bills. A majority of these people, when they, like the UHC, 50,000 today is just money that these MPs work with around, and they don't, it is not even enough. But I must say that our public health system is more of neglected. Neglected by who? By the people who make decision in terms of what to invest, or even to improve the medical services. I think that's why I can maybe let someone else to take it.
I wanted the microphone to go further back so that then it can come back to the gentleman here wants to speak. The lady has the microphone. Can I start with you, then to the gentleman? Then I'll come back to, yes, I'll span the microphone. Then I'll come back to you guys. So, same question from where he left us. Where do you think this underappreciation by employers is coming from? And then just speak a little about the work that you do and why you feel this is why we've reached where we've reached.
So thank you. My name is Mary Boniface. I'm the National Treasurer, Kenya Union of Clinical Officers. Starting from the work we do, like you've heard, clinical officers work as general practitioners who mostly work in the outpatient. And most of the times when you visit a facility in the outpatient, the person likely to treat you is a clinical officer. Further to that, as we talk about the specialties, 90% of these specialties are the ones who see patients, and especially outside the urban areas where the patient's access might be limited. In the urban areas, there is the advantage of, many healthcare workers concentrating around and giving the patients the advantage of having to make a choice between, I want to see this clinician, I want to see this doctor. But outside there, it is a problem. Actually, in some counties, you may go and find that there is only one clinical officer, ophthalmologist, and this specialist is shared among facilities. They are doing a cataract surgery in facility A, and later in the afternoon they are doing another one in facility B. And the struggle is real. You find patients waiting for long because there is shortage. And therefore, the issues that healthcare workers face are quite massive. And specifically clinical officers. Out there until today, there are still clinical officers clearing a queue of more than 200 patients in a day. And it is an issue. We have been talking about the shortage. We have been calling on the government to employ, but then that has been quite slow. And it is one of the reasons where we feel like we're not given the support that we need as healthcare workers to be able to offer our services. Because, when people are tired, when burnout sets in, then again, we start looking at, then will they be able to give the quality that we need? And it's not because they would not want to, but circumstances are pushing them there. And therefore, when we talk about the issue of feeling like we are undervalued, we are not appreciated, is real. Okay. Because these things that we talk about are basic human resource issues that are there in the policies. The Human Resource Manual talks about this motivation of workers, retaining, training and capacity building. All these things should be there. And the basics, like for example, if I have earned my promotion and I deserve, then why not? Why shouldn't my employer, who is county government X, provide money for that and promote me and ensure that I am working in the right job group and I am earning the right salary? And again, if this salary is to be paid, then I also don't want it to be delayed, because I have worked and I need money for my upkeep as a person, and also for, the basics, transport to come to work and all these things, which amount to demotivation. So when we talk about underappreciation, it is there, it is real, and the officers are feeling it, because like now the issues we have on the CBA, these officers are the members of the union. We have walked the journey with them, and like the GS has said, we have negotiated a CBA for 8 years. So these people have seen over the years this happen, and they keep asking, why can the government just commit? Because if you look at the details of those things, they're not things that are rocket science. They are basics. They are basics that fit to be negotiated inside a collective bargaining agreement. But again, the employer keeps delaying, keeps dragging, they keep complaining about budgets. They keep, to us, their excuses that really we feel like, then who should we turn to if the employer keeps creating excuses not to do the rightful things that they're supposed to do by the law?
We're having this conversation tonight, Mary, so that we get to understand the pain points of the clinical officers. We'd have hoped, of course, that Dr. Oluga would be here to also say what the government is doing. And some of the comments that are coming in, ask the ministry, what has it been doing in the last 35 days that these workers have been on strike? I'm sure the union leaders will tell us the kind of engagement that you've had with the government. But first, let's hear from clinical officer. What's your name?
They call me Raphael Tuju. I work at Mama Lucy.
That's what they call you.
Could you hold your microphone just close to your mouth so that you can, yes. Raphael Tuju.
Yeah.
Yes.
I'm a clinical officer, graduate clinical officer, and a specialist in masters in epidemiology, disease control, and biostatistics. As I've said, I work at Mama Lucy, where we are around 84 clinical officers. So,
how's the situation in Mama Lucy today?
The situation is very dire, because I must say that the people you see in Mama Lucy today masquerading as as medical workers are students and interns. And this is a disservice to the public, because what the patient that is going to Mama Lucy today, when he sees anybody in a lab coat, he or she believes that he has seen a doctor or a clinical officers. But suffice to say that we are having a government that doesn't care for the current mwananchi at hand right now. The government is focusing about Nyota program, about affordable housing, and is forgetting about the real issues that affect life. A healthy nation is a wealthy nation. And when we miss the point of where we are right now, because as you asked earlier, the patients who are coming, the general population, they appreciate the work of the clinical officers. But the government, starting from the national government, they have misplaced priorities. I'm so disappointed tonight that P.S. Oluga is not here. At one particular point, he was the director of medical services in Nairobi during the NMS. Up to today, we have not been paid our gratuity. And he is sitting in the highest office ever on this particular land. And he cannot even honor such an invite to address clinical officers. That is the kind of employer we are dealing with. When you come to Nairobi, Governor Sakaja talked about a city of dignity, order, and opportunity. What is the rationale of feeding children and forgetting about healthcare workers? When these children get sick, I wish you could focus on building. Of course, right now, when you're talking about WHO, focus is on health system management, infrastructure. But where is the human resource?
Where do you think the disconnect is between what the politicians say when on the platforms and then the implementation? Where do you place this disconnect? So, for instance, the governor, Sakaja of Nairobi, would happily go to every school in Nairobi to show the feeding program, right?
Yeah.
But paying you, I cannot launch it. I cannot launch something to have paid clinical officers today. This is a problem.
I think today you can imagine, today is 27th. For the last 1 year, it is the first time the county government has paid salaries on 27th.
Okay.
Reason why? We're on strike. Must we push the government to do its need? If he pays me a salary today, should I be happy? I should not be happy, because it is not a favor that the governor is doing to me. So the problem is, right now we don't have medical cover. We are offering services that we cannot afford. They have brought in a system of chief executive officers who have introduced corruption. Actually, it's corruption. The County Public Service Board is the one mandated to employ people in Nairobi. Right now, what is happening in Mama Lucy? The CEO is employing everyone every day without following the requisite requirement and the Labor Relations Act. And this is happening with our view. The president is watching. Everyone is silent. Right now, we signed a return to work formula with Governor Sakaja in last year, July 16th. We agreed that they're going to implement phase 1 and phase 2. We went for strike for 85 days. They told us, go back to work. We are going to implement. Today, they are telling us that we wait for the approval of the budget, the supplementary budget to the county assembly, who are in recess right now, is when they can come, they approve the budget, then we go back to work. Where's the priority?
Raphael, as I listen to you here,
Yes.
similar conversations to what the doctors in Nairobi have been saying. Because doctors in Nairobi were also on strike. So you're basically saying that clinical officers and medical officers have been on strike in Nairobi. This is the most populous county in the country, the one that is serving most people, and they've been on strike. Now, the grievances I hear you raising, medical cover, the pay agreements that you signed up last year not being honored. Let's just focus a bit on the medical cover. What do you mean you don't have a medical cover? So is it that you don't have any, including SHA, or is it that you don't have a private medical cover?
We did have a private medical cover. That was Jubilee MTIBA. But along the way, the other day, it was just abruptly cut off, and all of us suddenly, we found ourselves into SHA. Without any explanation up to today, there is no explanation as to why we were shifted into SHA. Suffice to say, as much as SHA is giving us SHIF, which is a comprehensive cover, facilities in Nairobi right now, up to today, if you go even in Nairobi West, I heard the other day in Metropolitan, one of our clinical officer had a child who has exacerbation and was due for just receiving a simple procedure like nebulization to be able to breathe well. She had a comprehensive medical cover, yet the hospital turned her away. So if this is being done to an officer who is working in the county government, what about the common mwananchi who lives in Turkana?
You know what stands out for me, Smart and Zaha, is that medical officers and clinical officers who work in public health facilities want a cover so that they can access healthcare in private health facilities. And I'm still at a loss here. I mean, we're saying that we don't trust the places that we work. I'd like to go and get care in a private facility, and yet I spend my day working in a public facility. Let's take a break. When you come back, I'd like to get into to understand.
We'll start from there.
We'll start from that point.
Yes.
Like, why? Are you saying that you don't actually trust the place that you work and you want us to come and seek care there? But let's take a break. This is the last word. We're having a conversation with the clinical officers in the room, from the leadership of the Clinical Officers Union to clinical officers who've been on strike for the last 35 days across the country. Like we've been told, 89% chance that when you walk into a health facility, a public health facility, the person you'll find is a clinical officer. Even then, it extends to the private health facilities as well. So when they are on strike, what does that mean?
Yeah.
That you have an 89% chance of not getting care when you fall sick. It's a big issue. Let's discuss it further when we come back. This is the last word. Back, this is the last word. We are having a conversation about clinical officers who've been on strike for the last 35 days. Are clinical officers appreciated? Is it a time that the government actually acceded to the demands by the clinical officers so that they can return to work and so that we can access healthcare? As we were taking this break, we were discussing one of the grievances that clinical officers have is the issue of medical cover.
Yes.
And they're talking about the private medical cover. Clinical officer Raphael Tuju told us that They were
Not to be confused by the other Rafa twins.
by the other, any other.
Any other Rafa twins.
Any similarity is purely coincidental. That they had their clinical officers, for example, in Nairobi County, had a private cover, and then they were told, now we are all moving you to SHA. You're under SHA cover. And it's one of the grievances that they have, right? Do you understand the gist of it, Zah?
You know, it's interesting now, like we were saying earlier, now I'm scared because if the potential of looking at what covers our medical doctors and medical health workers is a private hospital, then the question that we were just raising, do clinical officers in Kenya trust the institution of healthcare in Kenya generally? And are they resourced enough, or do they actually even believe in the system of healthcare that we have existing currently? So if you don't, then where do Kenyans supposedly go? And right now, especially during strike, what happens to patients overall? I think I just want to understand, what is healthcare for health workers?
I think this also lives in sort of this bigger house or bigger space where, as a people, we institute things, especially upon authority, that they would not face the consequence of the policies. Someone, wakes up one day and says, we're changing the entire education curriculum. Their children are in Britain. They're not here. But we've changed education system for everyone, all right? Members of parliament pass SHA in a record 2 weeks. And then they're on a private, tax-funded private medical scheme. So this is a problem that we all deal with. It's a complication of, I think, of being a Kenyan, that it's possible for you to decide how others are going to live and it's not going to affect you. But anyway, Latif, you had an urgent and straight question.
Yeah, that was it. And I think there's someone who was willing to take up that question. What does that mean? Does that mean that you actually don't trust the care
where
that
you work?
give? That you feel that I will not receive good care where I work. Right. You have the mic.
So much. My name is Stephen Mudhama, and I am a reproductive health specialist with keen interest in women health. I am also the chairman for Kenya Union of Clinic Officers, Nairobi County. And like my colleague and friend Tuju said, I practice at Mama Lucy Kibaki Hospital as a specialist in the institution. What makes me leave home at Lavington to Mama Lucy is to work and offer services. I don't go there to seek healthcare services. But it's sad that in the event that I get sick while at Mama Lucy, I can't access the service where I work. It's like a hotelier, where they work, where they cook, they're hungry, but they can't eat from there. They can't access. Because number one, Mama Lucy does not accept outpatient cover under SHA. My employer gives me a cover, comprehensive medical cover with Jubilee. Mama Lucy does not accept Jubilee. I don't just live around Mama Lucy. My family, my kids, wherever they are, if they are sick, they don't have to rush to Mama Lucy. Health should be accessible 24/7, and I should be provided with a comprehensive medical cover so that while I am at Makueni, I can be able to access that service. I don't need to travel to Mama Lucy, to Mbagathi, or to any public hospital. In most of the places where we live, it is not the public facility that is to go to that is the most accessible. We have so many private institutions. It is not like they have better services. I trust my colleague Tuju to attend to my kids than I trust a stranger at Metropolitan or any other private hospital that I've never known. Because I've worked with Tuju, I've seen the good work he does to kids and to patients. So it would be my best interest that my family, my kids and my friends are treated to at Mama Lucy. But leadership, governance, the systems, the way things are done, it is not possible. It's not working. Because I know Tuju is not paid on time. Tuju is demotivated. Tuju is not treated with the dignity that we were promised by our employer. Tuju does not have opportunity to advance his career. So Tuju is a person who is just there, put there to just offer services. I have my colleague Mudhuri, whom we have the same training, same number of years in school, but he is paid half my salary by the same government. That guy, it is very difficult to trust him. He walks to work all the way from Kayole. His kids are sent away from school. And this is a colleague that you want me to trust to attend to my daughter. It is not something that I am joy of, that I cannot take my daughter there, but it's because I know it's a broken system. It's poor leadership. It's poor governance. The governor could have best interest, but he has people who are letting him down. They are collaborating to make sure that he fails. The health does not work. Because explain how, unless he tells them, go agree with them and come back and disagree. How do you sit after striking for 85 days and agree that clinical officer who is appointed at an entry point of an intern to continue working at job group H as an intern, and we have a system that is working? That is not possible. You sit, you sign agreement, you agree we will do this today, we can do this other thing tomorrow, in 2 weeks' time we can do this. This is not possible, give us a year. Tomorrow they run away from the table. They don't do, in fact, they do completely opposite. I would say, like my friend said, like a relay. You start the race here, you give the baton to the county secretary gives to the CEC, CEC runs back instead of moving ahead. You cannot accept such leadership style in a county. And the solution, because they don't want to negotiate, they don't want to discuss with us, sometimes you are pressed to the corner to just call it off and face it on their on your account. So these are the things that we will not accept, because it affects us, it affects our families, it affects the community, and by extension, the country. It cannot work, and we can't get to Singapore if we are to Malaysia, if we are managing things this way.
It's too late. We are now going to Davos.
Can I allow me?
Yes.
Maybe on the issues of whether we trust where we work. At least some are good evidence that I have never seeked services out of public facility. That's to mean I have trust. And my wife has done delivery all of the time in the public facility, including Mama Lucy. So to that extent, do we trust where we work? We do. I think Mudama has explained the situation that normally we face. It is circumstantial. That, for instance, you have a cover that is not accepted where you work. So that one will throw you out of the balance, and it cannot be a measure for that trust. So, and that's why probably we feel the whole issue about now this, about what is happening, private insurance, public insurance, I think it's about the funding system that is already a failed system. I have a cover that is, if it's not updated today, it doesn't serve me. At the end of the day, you still pay. It will not come back to give me the services. You have delayed me accessing service, or you have pushed me out to go out of pocket. And that is the kind of broken, policies that are there. They provide for what is supposed to be done. Nothing is happening. I can give a good example. At least I go around the counties. Today, the whole of last year, the county government of Marsabit refused to offer medical cover for any healthcare work. We have been pushing in, out. People are on strike. Like now, they have been on strike even before we started this strike. It goes around, and then they go to court. They promise to do it in the next 1 month. It's not there. We have even been contributing to some of our colleagues who need those services. So that's the dire situation that normally happen. They are unhighlighted, cases that really feels that if they were to be highlighted, it brings a question of how management is happening for the healthcare workers, especially under the county, and whether then we need to look for a way of centralizing the management of the healthcare services.
Wasn't it problematic before? I think the whole reason why healthcare services was devolved is when it was centralized, it was very problematic. It was managed from the top, and it completely lost citizens out of that process. That's how we ended up with KNH.
James, I think it is NTV that highlighted a case in Tana River where a lady had died waiting to get, after a snake bite, waited for more than 16 hours to get antivenom. They do not even have an ICU bed. The governor has been there for 10 years. He's now actually leaving and he wants to contest for Senate. There is no services. So if you tell me then devolution has worked, probably it has reached, it is not working. I don't know whether then that it is a position where we look at health as practitioners, as also service seekers who seek services in those public facilities, and we feel there's something lacking. Now, did we learn when we had COVID-19 that we had to centralize directions, management from Afya Center, Afya House? That everything had to come back. Governors could come to congregate at Afya House for directions. So did we learn?
So the question is asking, and it's a fundamental question, why we feel, because I've had this before, and it's an intellectual question, why we feel centralizing things makes things work, okay? Issue of your pay, for instance.
Yes.
All right? The PS is not a devolved officer. The national government, all right? You discussed on the issue of healthcare workers. I think the one that was agreed by CS Duale in December, on having pays for the section of clinical officers who he said that the money would come, I think, in January or February. That money hasn't come, part of your CBA and disagreement. So this national government. So we can all point out failures from both systems, but I'm really interested in why we feel nationalizing health care and health services and health policy and how it works is the silver bullet. But what is that one thing that makes this the only thing that works?
I think there is what we give it to counties, and they have done very well in terms of infrastructure, actually coming up with buildings. They are blessing. Like in Nairobi now, we have close to around 20-something facility which do not have healthcare workers. I've gone to Meru, around 11 facility, no healthcare workers. Because every MCA want a facility there, but there's no healthcare workers. Even those that have healthcare workers, still they do not meet the staffing norms.
Right.
So, and the majority of the public facility you go, you'll be told that labs are not functioning because there's no reagents. You'll be told that in pharmacy there's no drugs. So what is it that really makes then the county look like they're working? By the way, there are counties implementing the national policy become a problem. I can tell you, like today, after 15 years, 16 years of devolution, the healthcare workers in Kirinyaga have never received even a single promotion. Fight after fight is like you are treated like you are actually prisoners in your own country. No one celebrates what they are doing. So those are people you trust with your life. So then when you centralize, for instance, like now we have a career guideline that is approved centrally. You have counties, even at the level of the council of governors, they're giving a wrong direction that it should not be implemented. A document that has forced people to go on strike in 2016, 2017, all the way it was approved in 2024. So you find that a broken system where there is even bad faith between, or rather bad blood, between the council of governors and the Minister of Health, it now causes pains to healthcare workers and patients. That people do not see eye to eye. The issues of the UHC, for instance, do you think it need to take more than a year for them to agree there is money provided? President has made several declarations about the same matter. No one is taking actions. Is it something that we need to celebrate? The national government negotiate for people, like for instance, Global Fund. You negotiate with them because you are the helm of that. Then you place them at the county level. Those are in your facility. When the Global Fund leaves, you have an agreement to transition them to P&P. You are the one to provide money. You have not done that. People still are working at the counties, and you continue saying those are the county level. They detach themselves from there. So we feel that this fragmented health system is not working. Maybe, and that is why what pushes us to feel, even if you don't want everything to be centralized, but the management of the human resource should be looked into, because it also causes family, You have been married today, you are in Vihiga, someone is in Mombasa. When you want to move and stay together, it become a problem. The management of the HR issues become a systematic problem.
So that function needs to be centralized. The function, at least, on how it deals with.
Point.
Yes. Yes.
Yeah. If I can also contribute, and I think when we talk about centralization, we tend to probably limit our options. Because whenever you talk about centralization, I know if the governors are listening, already they are up against that. But what we are saying it has been 15 years where we took a paradigm shift in how we manage our healthcare system by devolving it and giving it to semi-autonomous centers, 48 of them. That is the national government and the 47 counties. After 15 years, it is time that we ask ourselves, now that we changed how we manage our health system, can we take an audit of the health system very objectively? We know we have around 6 components that make a good health system. Leadership and governance. Let's audit. Is it working? Do we see integrity? Do we see the issues of corruption? The issues of ensuring the ethical issues and moral issues of ensuring that you do not have service disruptions. Look at the HR. And even beyond that, look at the regulatory and the legal and policy framework. For example, you go to the Ministry of Health, you find a very good document that was done by CS Nakumicha about, are we ready for UHC? And it's very candid. It actually says that we have a dire shortage of health workers, that we cannot actually be able to guarantee Kenyans of that access that we are talking under UHC. For example, for clinical officers, it says we should have been 24,000 in the public facilities, yet we are only 6,000. When you go to the other side of the PFM Act, it tells the governors that you have already exceeded your ceiling of 35% of recurrent, you cannot employ more. Another question is, you already have legal and policy environment with a lot of disconnect. On one side, you want more health workers. On the other side, the Auditor General is on your neck. Why are you employing more and you have reached the ceiling? So we want an audit so that then we can be able to see what do we do so that we go over and above the PFM Act. And that is where we have been coming from as health workers and recommending a health service commission so that this ceiling of 35%, we can actually be able to break it. And the health service commission, now we will not have this ceiling. The 35% will be probably administrative cost. So we look beyond the centralization or the devolution. We look at each and every component of the health systems, and then we can agree on this component. If we are talking about essential supplies, I think 50% of the time, we do not have drugs in our hospitals. We do not have reagents. A victim myself, at some point my relative got a stroke. We went to Thika level 5. She was admitted for more than 8 hours without being by, not even a nurse, could not see them. I had to travel all the way from Nairobi to Thika so that she can be seen. Then, there was no drug. We had to purchase everything from outside. When we needed a CT scan, so that we can even know whether it was safe for us to transfer her, we were told the CT scan cannot work because there are certain things that have not been bought by the county government. And so that is what we are saying, that we are not starting from a mindset that we want to take it back. We are starting from a mindset that as a country, because we took that shift, can we now take an audit and ask ourselves the questions? Is it working? If it's not working, where is it not working? And what are the solutions?
Do you think, Natif and Zaha, that, I mean, I 100% agree we need to audit devolution. Is it, what, 16 years now into it, and it's a good time for us to see what the document we gave ourselves and what it's done or supposedly done and where we failed to either meet the standard. But a key question that keeps arising from this process is we never had political class that walked into office and wanted to implement the Constitution as is. I don't think there's ever been an attempt by most of the political leaders that we've had since 2013 to actually implement the Constitution as we thought it should be. Because this Constitution is actually a document that Kenyans, and it comes out of the fear. And the question about centralization, which will be very emotive, is this simple question that once we start saying things don't work in our small structure, it needs to go back to this big structure, then Kenyans start losing themselves, all right? Then all facilities become a place where we cannot access because we have no one to ask, because it is either the president or the CS. And that is the danger that Kenyans are guarding against. So as we talk about how to audit, should the question then fundamentally be that we continuously elect people who don't care about governance at all? They care about themselves and seeing themselves, and they are in this fantastical space of performative politics that I'll build facilities. If you elect me governor of county whatever, I'll build 20 facilities, all right? And I'll walk out as the guy who did a lot of work in my county.
I think I agree with what the union is saying. Let's audit and let's see what works. And I see also the argument of, if we recentralize, where shall we stop? All right? If we recentralize, where shall we stop? Peterson is raising a good issue here, that counties have a ceiling of how much you can spend on salaries, for example. Now, if you exceed that ceiling already, it's a governance problem. It's a governance problem.
Yeah.
But there's also the issue of funding. How do we fund devolution? If we are still at a level where we keep talking about funding devolution at 20%, only 400 billion shillings goes to devolution, while we have a budget of 4 trillion shillings, that's absolutely nonsensical. If most of the services, especially the human-centric services, agriculture, health, and so are devolved, more money should be going to counties.
Right. Exactly.
So it also expands that 35% is a 35% of a higher amount, which can then employ more people. So there's all those debates, and I agree. Let's open up this conversation and look at all options with an open mind and see what works.
Okay.
And I see, George, you want to respond to this, but before we accuse you of holding the mic.
Is that counties have ceiling in terms of what 35% of what they can. Do we have ceiling for corruption?
Yes, 0.
So, all right. Then we should be discussing things that really, because we know that they use that for purpose of convenience. Yes. Because then if we were to discuss about corruption, every county has a question to answer. Okay. Misappropriations.
Yeah.
And misdirection.
So they're using that as an excuse?
Yeah, it should not be used.
Okay. All right. Yes, please.
Okay. My name is Farid Lokpapa.
Sorry?
My name is Lokpapa Farid.
All right.
I am a clinical officer. I serve in Mama Margaret Uhuru Kenyatta. You had asked a question of whether we are motivated or whether we are appreciated by the government. The answer is no. Because 2 years ago, the document that is supposed, that talks about how a clinical officer is employed, how he retires, how he progresses to how the clinical officer progresses. That document, since 2 years ago, it has not been implemented. We have seen counties through the COG, and we are wondering whether COG is the union of governors or what is it? That is the big question that now it has left Kenyans wondering. Because they sit down and they discuss. Because I understand, like for me, I'm an employee of Nairobi. Nairobi is responsible for me, and I'm responsible for the patients I serve in Nairobi and the patients who come to get care in Nairobi. So, and my files are in Nairobi. We have a document called Career Guideline. This document, it has ruled out that a clinical officer entry level, the minimum entry level is Joe Group J. For 2 years, clinicians have been serving Joe Group H which does not exist. And we had a meeting with the Nairobi governor, with the Nairobi county, and we came with a good matrix. We sat down with the senior officers, the people that on the table, they are very serious. We were there with the county secretary, the CECM, health, the board, every stakeholder was there. And in front of the media, we signed a return to work agreement. And they said that, and they even gave timelines. For phase 1, it starts immediately. Now it's 6 months. We are wondering, the budget that we were told that there is a budget to implement the return to work agreement, where did that budget go? Were they trying to play with the minds of clinical officers? So when you are asking the question of whether we feel appreciated, the answer is in the writing. They told us that phase 2, which talks about promotions. You can imagine a clinical officer who was employed 10 years ago has only received 1 promotion. And this clinical officer is seated there, seeing patients, and is only paying a risk allowance, which I cannot even say in the media. A risk allowance of 3,000.
What is a risk allowance?
Risk allowance is I think the definition of risk allowance is just it is in the risk. It's straightforward.
Not.
It's like
No.
Yeah, it's straightforward.
It's not straightforward. Just please explain. What's risk allowance? You're given an allowance for the risk.
Maybe I should keep my point because you'll interrupt me. I'll come to that kindly. So, risk allowance. This is a clinical officer. This is an officer who sees patients, maybe TB patients, and maybe patients who have hepatitis.
Yeah.
And what all you are demanding, it is a small increment.
Okay.
When we are asking for a small increment, like we are only asking for 4,000 increment, but the account tells us there's no budget. Yet we have counterparts who are receiving an risk allowance of 20,000. Are we appreciated? No.
I see.
Another point about whether we are appreciated. We are equally learned. You have heard from my chairman that we have clinical officers with the PhDs, but have you ever had a clinical officer heading those higher positions of PS or maybe director clinical services in the county? Yet the constitution gives that it gives a balance for anyone can attain those levels.
Right.
So we are not appreciated. Another issue is about the disrespect that we have received from Council of Governors on 22nd December, and this is embarrassing. And the Kenyans should really take note about this. This strike has now entered 56 days, because I'm counting 21 days of strike notice that was given, that the government had a chance to improve, to alleviate the suffering of Kenyans. Because I know Kenyans, we believe in UHC, universal healthcare coverage. But now a patient now is forced to go to private facility, which is against which is against UHC, which essentially is about its concept is about patient getting care without straining financially or suffering issues to do with the distance. But now you see a patient in a patient that I see in Kariobangi now trying to find care in other facilities without with a lot of anguish. The government had opportunity to alleviate this strike. Do you know what happened? The Ministry of Labor called for a reconciliation meeting, and I was there. The COG was to come, the Ministry of Health was to come, so that we can call off the strike or suspend the strike. We discuss. We are not animals. You can just come and we discuss something and you say suspend, and talks continues. They did not come. So who caused this strike of clinical officers? Is it Kenyan Union of Clinical Officers, or is it the COG in collaboration with the Ministry of Health?
Okay.
We were told they went on strike. They went on Christmas holidays, and that's why the strike started. And now we are on 35 days of strike. Still, they're taking time. Already our CBA is negotiated. Only what remains, it is signing of the CBA. And that today I'm telling Honorable Duale that this pen I have here, I'll come with it tomorrow at the Ministry of Health, and the COG will come tomorrow, and I'll issue this pen. You sign our CBA, we go home.
That's it.
And another issue before I finish this, I want to talk about something about healthcare financing. Healthcare is something that is very important. Somebody today told me it's better I survive with 100 shillings, but I'm healthy. Right now, Kenya is suffering. If the problem is about the budget, because they keep on saying the budget,
okay,
and I'm proposing to the government, instead of building houses, I'm today ready. That housing levy, nikate ingize kwa SHA, or ingize kwa counties, so that it can increase the budget to save the life of Kenyans.
Thank you.
Because building those houses,
thank you,
under the Kenyan is suffering. ISID. Thank you so much.
Asante. You know, there's and maybe later union leadership will come and tell us. There was a meeting last week at the Council of Governors, chaired by the chair of the Health Committee of the Council of Governors, Abdul Samad Sharif Nasir. He released a statement saying, you know, we've reached a good agreement with our clinical officers, and, you know, talks are progressing well. You'll come and tell us what happened to that, because you're still on strike, despite that meeting last week, which was appearing very positive from the Council of Governors. And now we're hearing you saying that, you know, still COG is on strike. It's not the clinical officers that are on strike, right? Peterson, do you want to give us an update on that?
Yeah, thank you. And I don't know if I can start with your question on risk allowance.
Yeah, no, start with the other one. The risk allowance is actually important for you to explain. Because
okay, start with the other one. That's okay. So last week is true that for the first time since 23rd of December, when we went on strike, it is on Thursday last week when we had our first meeting with the Council of Governors. And since we went on strike, we have not had a single meeting with the Ministry of Health. And it's good to qualify that with the Ministry of Health, our CBA was concluded on August of 2025. All approvals from Treasury and SRC were given by September, and since September it has been printed waiting for the CS and the two PSs to sign. So we went on strike because the leadership of the ministry was not feeling like signing a CBA, because there is no other plausible reason as to why that happened. On the side of the COG, on Thursday, it's true that we met, and since then, we have been in negotiations, including today, I think every day since then, except for Saturday and Sunday. And we are gaining some inroads in some of the things, but on two issues. And I'm happy that we also have some health workers who are in the UHC staff and the Global Fund staff under the contracts, and they'll be able to actually explain their situation and their plight. The two levels of government are non-committal. For example, as my GS clearly said, we have Global Fund staff. These are people who were employed in 2009 when this country was really under the scourge of HIV, realizing that many of our HIV patients were dying from an opportunistic disease called tuberculosis. World Bank came in and they had an agreement with the government that we are going to give you the money to employ these people to help us with the TB and the HIV, but once we are exiting, the Treasury is going to provide that money so that they can be employed on permanent basis to continue serving Kenyans. When the Global Fund exited in 2023, the government decided to only absorb those under the national facilities, national government facilities, and left about 94 of them who are under county government. Yet all of them came before devolution. They belong to the ministry, their contracts are with the ministry, they have never been devolved. But the CS says that those who are working in the county government facilities, they are not mine, they belong to the county, yet they have never been transitioned. On the other side, we have the UHC colleagues who have worked for this country for 6 years, since COVID-19 started, and that is when they were employed. Even some of them actually lost their life to COVID-19. But instead of appreciating them, even when the president in public has pronounced that he's going to do everything to ensure that they have been converted, their contracts have been converted to PNP, we are still being tossed between, you ask the national government, they tell you the problem is the county governments. You ask the county governments, they tell you no, the problem is the national government. And that is where now we are having a stalemate, because then we said we must then have these two levels in one meeting, so that first they agree, huyu mtoto ni wa nani? Because everybody says, no, this is not mine, it belongs to the other person. So we need them to come and tell us who actually is responsible. Because on the issue of Global Fund, it is clear with evidence that they actually, all of them, belong to the Ministry of Health, but now it's throwing them under the bus. And once we are able to agree on that, I believe on the other issues, we are on the CBA, we are almost actually concluding. But then as a union, we cannot accept to leave the weak ones behind, and especially the UHC. And for you to understand the dire case, you know, we have many of them with mental health issues. In 2024, around April, a young lady called, was it Gladys Rimoi? Gladys Rimoi went into depression, got into psychosis. She committed suicide and actually took her own daughter in that process because of this issue and quagmire surrounding the Global Fund. But even that did not move the ministry and the Council of Governors to go on and find a solution for this. And I think that goes further to show you the question of why is it that we go on strike and the type of people that we are dealing with. And I must also inform Kenyans that it is not only about the clinic officers when we are fighting for this. One of the reasons that we are fighting for them to get job security is so that these mental health issues do not arise. We have so many of our clinicians who are having issues of substance abuse, who are depressed because they don't have job security. They are being paid a salary that cannot even sustain their families. And then, because of the shortage, instead of seeing around 35 to 38 patients, according to the WHO, within 8 hours, we are forced to see more than 100 patients. And so we are fatigued. And even when you are coming out of that, then you are not even able to feed your family. So one of the items in the agreement of 2024 was, can we now employ enough clinical officers so that on our side, we lessen the burden, we don't have mental health issues. But on the other side of the patient, you don't have long waiting times when you come to hospital that usually causes these complications. And also, we don't misdiagnose you. And I have said this many times. There are many patients in this country who are misdiagnosed. There are many medical errors, not because health workers are not competent enough, but because by the time we are seeing you, we have seen more than 100 patients, we are fatigued, we are stressed. We cannot think straight.
So just to answer the question then, this meeting for last week with the Council of Governors, what was the outcome?
Pardon?
What was the outcome of this meeting?
So the outcome...
Because the governor, in his statement, he said, you know, we reaffirmed our collective commitment to addressing the transition-related challenges affecting UHC workers and Global Fund programs, utilizing existing intergovernmental frameworks we agreed on the need to develop and operationalize the harmonized career progression guideline. It shows that there was something that you
agreed to things.
And there were photos, and I can see you here, Peter.
So what they did, they just initiated a negotiation process. After that was around 30 days or 28 days of the strike. That is when they were initiating the negotiation process, and now we are in that process. We have been on it daily, and tomorrow we still, from 8 a.m. in the morning, we'll still be in negotiations. Hopefully, we might be able to reach somewhere. But then with the ministry, up to now, they have not called us for any meeting, and so we don't know when we are going to get out of that quagmire. And I don't know if maybe I'll come back to the risk allowance later.
Yes.
But I think what I need to say is that, as I said, we issued our strike notice on the 2nd of December last year, and after 21 days, we began our strike on 23rd. We expected in between that this meeting that the governor is talking about, that's when we ought to have had meeting to alleviate this strike. This meeting of 22nd that now the governor is reporting was as a result of all the governors meeting in a hybrid meeting on 15th of January to discuss how the strike is affecting the counties. Then they agreed now to have this meeting. Now we had a meeting on 22nd, we discussed as they communicate. To their extent, they felt like whatever they communicated was enough. But what we are saying is, we clinical officers, going by the question that we were asked here, the appreciation we want is not praise. Is sign the CBA, clinical officer will go back to work. Pay the arrears you owe the staffs of the Global Fund, clinical officer will be back to work. Please transition the healthcare workers, the UHC staff and the Global Fund to permanent and pensionable terms, because those are what we are pushing for. But of most important, the fourth item is implement the approved salary rates, phase 3 and phase 4 that has been approved by the constitutional body that is mandated to do so, the SRC, which the county have not been implementing. They are in arrears. Let them pay. So clinical officers will be back to work and feeling at least appreciated. What we do not want is those, because those are just rhetorics that do not add value in service delivery. As we do that, it is good when we receive patient calling and telling us that they want our people back, they want, and I've seen even some of the recorded clips in Kericho, our patients were looking for someone who they want to see, and it's not in the hospital. We value the trust that clinical officer, the patient, the trust that patients are giving clinical officers, and we want the same reflected from the employer side. And that is how they can do the reform. They continue preaching about the healthcare system.
Thanks, George. I must say that the governor of Mombasa has reached out and would like to comment here. We're just trying to sort out the technicalities of whether we're able to actually pick a call, because he'd like to also respond to this particular issue. The chair of the Health Committee of the Council of Governors, whom you met last week and with whom you're having these daily negotiations that you've said. But as we see whether we can sort that out, let's come back into the other issues. And today, the Daily Nation had a good, was it today or yesterday? That we had a good story on the plight of the Global Fund workers. Now, for the ordinary person like me, I'm at a loss. There's workers that are employed by the county government, there's Global Fund, there's UHC, there's so many fragmentation of different work.
Should you care about all these differences?
Yeah, I mean, who are all these people? Because I hear they're going on strike because Global Fund.
Yes.
Next time they're going on strike because UHC. Next time they're going on strike because I don't know, ministry. Who are all these things? And why not put this money into one pot and just employ? It's just a kind of conversation we've been having about bursaries and schools.
Yes. Exactly.
You're getting bursary from MP, from MCA, from governor, from president, from
well-wishers,
and you just want to go to school.
Yes. Everyone is giving a bursary. Yes, please. You want to solve this problem for us?
Yes, good evening. Let me stand because when
Hold the mic closer, please.
I might not be audible enough. So let me join my colleagues to say thank you for giving us this opportunity to air our issues as clinical officers. And on top of that, I'm one of the Global Fund staff who has been working in the counties. Some of us began in 2009, others, like me, I joined in 2016. And the Global Fund begins with funding healthcare in HIV, TB, and malaria. So all of us, we were receiving funds from the same pool. Then it happens that the transition, the agreement between the Ministry of Health and the Global Fund, once funding of the staff comes to an end, the government should initiate a seamless transition to whereby everyone should be given a permanent and pensionable jobs. So for us who are in the counties, we didn't reach there. The contract ended in 2023 December, so the transition began. We received payment for 6 months from the government. Then from there, those of us who were in the county were exempted out of the payroll, and that's where our troubles began. So it's now the 19th month, no salary, no medical cover. For those who are on payroll, would bear with me that if I delay for a month or two, causes all the suckers and problems around due to lack of the funds that you are to sustain yourself. For us, the 19 months, I don't know how we can even talk about it. Because
so let me ask for clarity. You've not been paid for 19 months?
19 months.
Not a single coin?
Not a single coin.
And you go to work?
You are supposed to be at work, and once you are not there, you are patient. Wamefika.
Okay.
So,
how is this group of people, the Global Fund, yourself and colleagues, how are you surviving?
So, that one, it is just by God's grace, well wishes once in a while, and the rest, it has been unbearable for quite a long time. Families have been broken, people have gone into depression, they have gone into all sorts of problems because they can't sustain themselves. And you and I will agree that the biggest wealth that we can have is you being healthy. And as a healthcare worker who is supposed to offer the highest standard and the quality healthcare services to the Kenyans, yourself, you are not healthy. So it begins, it's just something that you find everyone is just going into depression. All the time stress levels are high. You can't even get good sleep. You can't even feed yourself well, such that your body is able to resist, even to build immunity, to resist some small conditions hapa na pale. And then, to make matters worse, the patient you are supposed to be seeing, most of them TB patients, this is an airborne disease. So you keep getting exposed every now and then, and you are not healthy. So we are, up to now, we are more worried of our health ourselves than even the patient that we are treating, because we are not sustaining ourselves, which is the National TB and Leprosy Program.
At the Ministry of Health?
At the Ministry of Health. I don't know how it came out that they should transition, those are at the national level. Yet, we were receiving funds and payment from the same kitty, and then decided for us, 94 of us, should just be left out, and no one talks about, and no one even. We have written memorandums, we have petitioned Parliament and Senate, not once, not twice, and we have always been in those offices.
Okay.
And all we meet is an understanding statement, how they feel our pain, how they should be acting. But now when it comes to acting, that's where the line is drawn.
It drops
Because
at that point.
we have been managed for the last 18 months. I don't know, it's the high time, I think the concerned ministries and the government bodies that are responsible, because it should be a coordinated effort. The public service, the Ministry of Health and the Treasury, and then the Parliament that allocates resources to the ministry.
Okay.
That it is not something that is can take even a day or months.
Yeah.
It is just something that needs goodwill from people who are concerned, and they act
implemented immediately.
immediately.
We have Abdul Swamad Sharif Nasir, the governor of Mombasa, on the line. Let's try technically and see whether this is going to work. Governor, we have you on the line, and
Eric, how are you?
Very well, thanks. I don't know if we're able then to just pick this up and to put it on air. Governor, in the conversations that we've had this evening, the issues and the plight of the clinical officers is actually big. And we understand that even for you as Mombasa County, the majority of the healthcare workers are clinical officers. They've been on strike for 35 days. You had a meeting with them last week on Thursday. We just heard from a worker who has been under the Global Fund program talking about 19 months without pay. What exactly is the Council of Governors doing to address this particular strike?
First and foremost, for avoidance of doubt, Eric, I'm the one who really pressed to be able to get a right of reply. The two gentlemen, I think George and Peterson were, and I think the others as well, will also appreciate and agree this particular meeting with the COG was actually initiated by ourselves as COG for us to be able to sit down and be able to agree on way forward. The issues that they raised, one of them was on the hardship allowances. These are matters that every Kenyan is guided by SRC. We agreed with them on these matters. In fact, the SRC asked us as COG that pay them this amount, subject to availability of funds, increase that. We committed ourselves on behalf of all governors. It was myself together with Governor Sang. We had Chiboy and Anwai Guru who joined online as well. And we all agreed that we are committing that whatever SRC has said, we pay now. We're going to pay you everything, including arrears. 2, whatever it is that they had actually pegged as what would be ideal on availability of funds, we are committing from next financial year, we're going to add it in our budget so that we can be able to pay you on that. The other issue that actually ended up propping up was not necessarily strike related, but the issue of the career guidelines. And we did inform them that the Public Service Commission had actually done an error, and they gave an advisory on a public service commission, but then they rectified that error and they said that, look, this has got nothing to do with county staff, it has got stuff to do with national government staff. We did tell them that we will work with them to be able to agree on the matters of the career guidelines so that they can be at par. Every single clinical officer working in any county in government in Kenya can be able to be at par and grow at par. The other issues that they were able to raise, and I was so adamant, and I told them we've cleared literally everything that is capable on our hands as governors. Why don't you simply sign this CBA? One of the issues that they've not talked about, and I've not heard them, probably they have, but I did not hear them raise this particular matter. And I think it is an issue because I've been getting briefs from the Council of Governors Secretariat. One of the issues that is there, and this is something that we have even signed with the Doctors Union, clinical officers provide an essential service. And the courts had ruled that in the event in future there's going to be any form of industrial action, then they need to ensure that as that industrial action is going on, we give them their right to be able to do that. on the unforeseen circumstances that it does happen. However, there should be a minimum amount of clinical officers who will be working. It is something that the courts even pronounce themselves on, which is something that till now, I'm hoping tomorrow they will agree, because we've worded it in the best way possible for the CBA. I've begged the leadership, and I told them, be on record that you've got now, we need to be able to sort this. You need to have a CBA, so that at no given time do you always continue going back and forth saying that you don't have a CBA, you don't have a CBA. Let us come up with something that is going to be tangible. They've raised the issue of the global health and the UHC stuff. For avoidance of doubt as well, Eric, the amount of money we are actually talking about is not millions, it's billions in terms of wage bill. And they also failed to state that we showed them a letter signed and committed by the Council of Governors, signed and committed by the PS for Health, Oluga, to the Commission for Revenue Allocation, indicating that in this cycle for revenue allocation, it is important that other than the minimum amount that is due to county governments, it is vital for the amount of money that is due to global fund staff and UHC staff is going to be included. If you're going to enforce and say that take everyone on a PNP basis, and there is no legal mechanism on how the money is going to be able to come through, dear Lord, please tell me, how is salaries worth billions going to be paid? There's some things that are even beyond us. Even if Treasury does say yes today, the event that Parliament decides, because at the end of the day, the budget approving process has to pass through Parliament and has to pass through both houses of Parliament, National Assembly and the Senate as well. We showed them this letter, that this is what we intend to do. We showed them the commitment that was there. I literally told them, be on record, and in their own words, they said, Governor, we're in agreement with everything. However, we have our bosses to be able to report to. And they had, I think, their delegates conference where they said they need to go back to their delegates conference before they are able to sign on anything else. Yeah. Coincidentally, I even have it on my call logs. George will be able to agree with me. I was in conversation with him. I think if I look at my phone right now, I can tell you the last call that I actually made to him when I saw his missed call and I was in a meeting, I returned his call at 7:11 today night. 7:11 tonight, where he actually told me, Governor, I'm hoping that you can be able to whip, and you yourself are going to be able to come up with a way so that you can be able to sign the CBN, the return to work formula. As of 9 o'clock tonight, whilst people were prepping themselves to come on NTV and say otherwise, as of 9 o'clock tonight, I was on phone with the Secretariat of the Council of Governors, giving directions that this is how the CBN, the return to work formula, needs to be able to be done. We have been talking. I've seen the gentleman saying that he's got a pen. Trust me, the COG has enough pens. We only need goodwill. There's some things that are beyond us as the council. There's some things actually, and it's not my place to talk about the ministry, but there's some things. First of all, clinical officers who are working at the ministry, and I think Peterson can be able to confirm on this. I think they're just hardly about 100, vis-a-vis those who are working in county governments are close to 7,000. So there's a huge difference on what it is that can be committed by national government and what can be committed by the county governments. But it's unfair to state that there was literally no goodwill that was portrayed. I asked them how long that particular meeting took. We sat down there. Governor. We went through the numbers with them. I personally chaired that meeting. I was with Governor Sang, and the others were able to join us online. We were able to thrash out everything that is in relation to the county governments.
Thank you, Governor. Thank you for this, and for calling in and for sharing. this particular one. I think let's give Peterson and George just an opportunity to respond to this. You hear, and that's why I was asking earlier, from the update from the governor last week, and from what you had said earlier, that you are already progressing the conversations. Are you ready to sign an MOU or a CBA or a return to work formula with at the level at which you've discussed so far? And number two, what is it that you need for you to feel that the Council of Governors has done all it could do so that clinical officers can go back to work?
Yeah, thank you. And I think what the chair held, His Excellency Sharif has said, is not any different from what we have
his
said.
voice is got a bit of an echo, so I don't know if he could be able to speak a bit louder, probably. Or I'm sorry, it's just that it's over the phone and not through the.
But just as we have the governor, I think there's a direct question here that we shouldn't lose, because there's a lot of issues to go through. The gentleman from the Global Fund has said they have not been paid for 19 months. And that's a very separate issue. When do we expect the government to pay the clinical officers who are under the Global Fund? Their commitments have been made. Do we have a direct answer for that?
For these particular employees, their payroll, you need to ask them where the current payroll comes from.
They don't know.
That payroll for Global Fund and the others, the payroll is actually not from the county governments. And when the funds were coming in, even the employment letters were not. The goodwill is there to be able to transition all these employees to be absorbed by the county governments. Every single governor has been in agreement. Every governor has asked and tasked me, tasked the chair, you need to be able to give us a solution. And the only solution out is for us, by the way, Eric, and I think that the team there is aware of this as well. There is also another danger that if this is not passed quick enough, that some of these contracts are actually expiring. So we're going to have a triple effect. Effect number one, you've got people who have not been paid their salary. Effect number two, you've got people whose contracts are going to expire, who are going to need their remunerations, in terms of benefits and all. But they need to, you guys need to state it the way it is, that we did, and we showed you the letter that we wrote to CRA, a letter that was signed by the CEO of the Council of Governors and co-signed by Oluga, where we told CRA, whatever it is that you do, when you're presenting your figures on the amount of money that is due to the county governments, you need to ensure that we have to absorb each and every one of these employees. If the goodwill was not there, if we had no intent to be able to do that, we wouldn't have committed ourselves to that extent. We did what needs to be able to be done. Are we feeling the plight of these workers? Of course we are. Are they playing an important role in all our health facilities? A madman would say that they're not. But at the end of the day, as the governor of Mombasa today, their clinical officers who are part of the memberships of the union will agree that today, because of proper planning, we have to be able to pay people's salaries on time. We have to cover for their medical cover, the comprehensive medical cover that is going to be paid, and so forth. But the amount of money that we're talking about, Eric, when it is amounts that are manageable by the counties, amounts where SRC said you need to be able to pay hardship allowance for this amount, and you can be able, upon availability of funds, increase it to this. We never said, let's go back to Treasury. I immediately committed 47 governors, and I said, this is something that I can be able to talk to the governors, because it's not in billions, it's in millions.
I guess the direct question here, Governor, the immediate question is, much as they are to be paid and they have been under the national program where the national government has been paying them, they have not received a salary for 18 months. What you're committing is in the next financial year, as the division of revenue and the allocation of revenue to counties comes, that there should be an allocation so that you can absorb them into permanent and pensionable terms. That is from the next financial year. How about the 18 months that they have not received pay?
Actually, coincidentally, the conversation that we had, which I believe lasted close to about 5 to 6 hours, and if it was not for the fact that they had not made a concrete decision because they said they had to go back to the delegates, I even gave them an opportunity and told them, why don't you sit down, use the room that is currently available, talk amongst yourselves, we will take a small break, discuss among yourselves, make calls to your colleagues, but they never raised this matter. If at all it was raised in that particular meeting, I would have actually probably been one of those people who initiated and said, you know what, as the ministry, it is your responsibility to be able to pay these employees who have not been able to receive a salary for the last so months.
All right.
Coincidentally, Eric, something else as well. We need to, again, this is something that if this had been raised to me, I would have been able to try and figure it out, because some of these programs have not been cancelled within a span of probably that long. So you need to ask yourself, why did this salary stop in the first place? I'm more than willing to be able to assist them on that particular matter. The Council of Governors is more than willing to be able to assist them on this and many other issues. All I'm asking is, what is plausible, what is acceptable, what is doable, what is within the current reach of the Council of Governors and all the 47 governors. We committed all these governors on that particular day for the hardship allowances. We committed all these governors, not in small figures,
Okay.
in hundreds of millions, and we committed all the governors, and we said, you know what, this is something, as much as it is a monthly amount, we accept that. Let us pay you your hardship allowance, whatever it is that was the minimum SRC had recommended. We will pay you that in arrears up to June.
Thank you. Thank you, Governor. Let's now hear from Peterson, and I think what you can do so that we can work it out technically. Just raise the volume of your TV so you can follow the conversation on your TV.
And then, Eric, I'm sorry. I was actually somewhere without a TV. I got a call that my friends were on TV.
Okay.
I was hoping to get them to sign tomorrow. Then I was told they're on TV, so I just used my phone. So I don't have a TV where I am. I'm somewhere where it's a bit in the bundu. My apologies on that. But I'll be more than willing. Look. Peterson, George, and the rest of your team, you have the support and the goodwill of the Council of Governors. You can take it from me. We talk about you in a positive way. We want to absorb you. But the right way for us to be able to do it is not castigating each other. This is not the way. And you know it, and you know that that is our stand as well.
I wanted to clarify, there are two issues. Probably we're mixing the UHC staff and the Global Fund. The UHC staff contract is still running up to April. And I believe that there are money provided to pay them up to June, which is not a question. The people we are talking about 19 months without pay are those who are Global Fund, the former Global Fund staff, and they are working under counties. They are purely under counties. Is the county that gives them responsibility and places them at their workstation. And to that extent, they have not been paid. We expected that actually it is the employer who should be complaining, because the person who used to pay is the national government, and they have not formally transitioned them to counties. Then the advocate for these people should be the council governors, the governors themselves, because they have staff working under them and they are not receiving pays. I think when we raised this issue, and our proposal was that the council governors immediately take up action and write to seek clarification from Treasury and also the Ministry of Health, who are directly involved in contracting these people for the last over 16 years.
Eric, can I be able to reply on that?
Yeah, put it on speaker.
Yes.
Eric, other than Treasury is a couple of individuals who sit there. Other than Treasury, I believe I think that was George who was talking, or was it Peterson? One of them. But I can tell you, Eric, other than Treasury, we raised it at the summit. Summit is the constitutional body that involves the chair. The chair of summit is the president of the country, and where he actually brings on board at his pleasure each and every cabinet secretary. Treasury were there in that particular meeting, and the Council of Governors was there. It is not even an issue of just us raising this to an individual. We raise this matter to an institution. And I just want to also tell you that it's not that the Ministry of Health have even said that they don't want to. The issue that is here is if they are going to be able to give some of this money as a conditional grant, the danger that is there, a conditional grant is something that is payable for a specific period. That means if it's a conditional grant for 1 year and you have been given a PNP, that conditional grant expires within that particular year. What we are after is a situation where by next year, we don't have to start going back again and saying that give us another conditional grant and another conditional grant and another conditional grant. What we are after is a situation where we can give people sanity, that they've been given permanent jobs. And that is what we're after. You know, if you say that we've not raised this matter to Treasury, that's unfair. Look at the communication that was there, the last communication from the last summit as well. You said it right, that the president has pronounced himself. But everything has to be able to start. The budget cycle, unfortunately, this is not small money that we're talking about. It's in billions. Unless they do a special supplementary, where that special supplementary, even if they were to do it, it would just include it for this financial year as a conditional grant. What we have proposed and have written to CRA is that the minimum amount that is due to the counties has to include the salaries for the UHC and Global Fund staff, who, by the way, is not just clinical officers alone. Amongst them are nurses, amongst them are doctors, amongst them are other staff as well. Are we feeling this pinch? Yes, we're feeling this pinch. But, I mean, it would be unfair to say that we were expecting you to do a letter to Treasury when what I have actually done is more than a letter to Treasury.
Okay. All right. Okay, so here's the thing. Hang on. It's hang on. NTV is happy to facilitate this discussion, but we are unfortunately running out of time and we cannot continue. This is not the best way to continue this conversation because it's back and forth and we'll never get the answers, okay? So Governor, thank you very much for coming. We've taken time to try squeeze in a lot of response from the Governor, and we'll have him, I think, tomorrow.
The staff of the Council of Governors have been burning the midnight oil, not for any other reason, but because we value you and we want people to be able to get back to work.
Absolutely.
Please borrow the pen from the gentleman and just go and sign this document. Whatever is within our reach, we will get it done.
That is Governor Abdul Sumad from Mombasa. I'm unable to continue that discussion in this fashion. It's not helpful. Okay? Ladies and gentlemen, let's agree that was the response from the Governor. You have a chance to meet him tomorrow and discuss in detail, all right? Let's not get it to the public domain, this back and forth that it's going to midnight, all right? Thank you very much, Governor. Let's wind this down, all right?
So I think the main issues that have emerged tonight is that clinical officers are essential to the provision of health in this country. And for many years, there has been, the whole discussion of how do we best take care of our health workers, clinical officers included. Issue of salary, the issue of promotion, which you say many of them have gone without a promotion for many years. I mean, this is not proper practice in human resource. The issues that you've raised as well in terms of the allowances, whether it's risk allowance and also looking at medical cover and protection, those are things that should be addressed on a regular basis, not having to get to a strike. And we need to get to a point in this country where we stop going on strike on matters that are like you said, very basic human resource stuff. We need to get to that level. I think as you have your meeting again tomorrow and you update your members after your meeting tomorrow, let's also push for that national conversation around, can we sit back and audit? We have strikes by health workers almost every quarter in any financial year. This must come to an end. What do we need to do to bring that to an end? Does the government need to listen to the health workers in this particular case, for this particular strike? Should they? Yes. Should the government also cede ground on many of these matters? Yes. Should the clinical officers cede ground? I think you've argued here that you've been ceding ground for a long time. 18 months without pay is not just ceding ground, it's ceding soul. That's a bit too much. A lot more needs to happen. And maybe, Zaha, you can give us the last word.
I think there's been a lot, and we're hearing from the governor, and clearly once again we're being brought to a situation where we have to crossfire and discuss what is best for our health workers and what is best for our public as well. I think for me the last word is the clinical officers need to be heard. They need that CBA to be done. Those areas need to be considered and very much addressed. We shouldn't be having a situation where this pen is here and not in that signing vote. So as we continue, and we look forward to the meeting that we're going to have tomorrow, just to ensure we see that the clinical officers are back to work, but importantly back to work with dignity, with care, and with appreciation that continues to support you in the work that you do in this country, holding the backbone of the healthcare system. And I think that is the last word.
Well, thank you very much, everybody, for joining us tonight. Thank you, clinical officers, for taking time to come and have this conversation with us, to shed light to the entire nation of the plight that you've been dealing with. And thank you, everyone, who has tuned in. From myself, Eric Latif, James Smart, and Zaha Ndimuli, do have a lovely evening.